Good morning. Buenos dias. Thank you for joining us today. My name is Marisol Aviña. I am the Director of Public Affairs at the California Endowment, and I am excited to welcome you all to today's Policy Perspectives webinar, The End of the Public Health Emergency and Its Impact on California. Policy Perspectives is a virtual space that brings together experts and partners to discuss state and federal policy issues that impact our state and communities. These webinars are nonpartisan and non-political informational sessions. So over the past 3 years of the COVID-19 pandemic, we have been receiving frequent information and guidance from our public health experts about what to do to keep our families and communities safe. And as part of the pandemic response, our federal and state policymakers enacted temporary policies and flexibilities that have helped our communities navigate the health and economic impacts of the pandemic. And a lot of this is changing now as the various emergency declarations and policies have ended or are ending soon. Today's webinar will focus on sharing key information about these changes and what it all means for the communities that we serve. We will not cover everything related to the public health emergency in this particular webinar, but rather we will focus specifically on public health, nutrition benefits, and healthcare coverage. All right, so now I am thrilled to introduce our program and our amazing lineup. So to kick us off today, we will hear from Michael Tora, who is the Managing Director at the Raven Group, and he will provide us an overview and status update of the various emergency declarations. After Michael, we will be joined by Emily Estes, who is the Deputy State Lead of the COVID-19 Therapeutics Task Force at the California Department of Public Health. And Emily will provide an update on what we as Californians can expect as the public health emergency ends, including some updates on vaccines, testing, and therapeutics. After Emily's presentation, we will have a panel conversation that will focus on the impacts of the emergency declarations, what impacts they have had on Californians, what the end will mean for the safety net benefits, and some of the policy landscapes to address some of the gaps in access as these temporary policies come to an end. And for that conversation, we are very excited to be joined by Dottie Rosenbaum, Senior Fellow and Director of Federal SNAP Policy at the Center on Budget and Policy Priorities, Laura Guerra Cardis, who's the Director of State Medicaid and Strategy, also at the Center on Budget and Policy Priorities. And last but certainly not least, we will have Alicia Emanuel, Senior Attorney at the National Health Law Program. After the presentations, we will have time for Q&A, and we encourage all of you to please post your questions in the chat. And I also want to take this opportunity to thank all of you who submitted questions ahead as they helped shape today's conversation. Also, this webinar will be recorded and will be made available along with all the slides and speaker bios after the event. All right, so now on to the program. I am gonna turn it over to you, Michael.
Great, thank you, Marisol. So the COVID-19 pandemic led to a number of really extraordinary policy interventions. We saw policies put in place, albeit temporarily, that for decades we've been told were impossible to do. Things like paid sick leave, a form of guaranteed basic income for low-income families with children, expanded access to low or no-cost healthcare, protections for renters from eviction, and so much more. So before we turn to our incredibly knowledgeable speakers who are going to tell us about what all this means for accessing health and nutrition services and benefits, I want to provide just a little bit of big picture context. So I've got a couple slides. This first one is really just kind of like a simple diagram that I put together to just illustrate the point that the actions that were taken have been overlapping in their effect. And the response, it came from every level of government, from federal to local. So there were federal emergency declarations that gave federal agencies the power, like special powers to take action. And Congress passed federal legislation, which gave those agencies financial resources to actually do things and temporarily created some new powers and new programs. And then you have the state and local actions by state and local governments who played a key role in administering many of these programs that were funded by Congress, as well as taking additional measures beyond what the federal government did. So as you probably know, California had its own state of emergency declaration, which actually expired a couple months ago. And then local governments also implemented orders that went beyond what the state and federal folks did. So, for example, a lot of counties in California had eviction moratoria right after the federal and state eviction moratoria expired. Now, if you remove one of these, it impacts all the others and also the way that policies are implemented and felt in communities. So now let's jump ahead. I'm not going to actually spend a lot of time on the next two slides, but if we can go to the fourth slide. There have been like 5 major federal emergency declarations as a result of the COVID-19 pandemic. And the White House announced earlier this year that on May 11th, so next week, it would end the national emergency declarations. There's actually 2 of them, the one in green and the one in orange down on the bottom, as well as the public health emergency declaration. However, Congress has taken some actions that change how we think about that timeline. So already back in last December, Congress actually passed a bill that set an earlier date in April to begin winding down the pandemic era Medicaid policies. And in that same bill, Congress extended some telehealth flexibilities for 2 years. So that's no longer tied to the emergency declarations. And then on April 10th, so less than a month ago, President Biden signed a joint resolution that had been passed by Congress, which officially terminated the National Emergency Declaration under the National Emergencies Act, so the one that you see in the green box there. Note that the resolution didn't say anything about the National Emergency Declaration under the Stafford Act, probably because that, in practical terms, it mostly wound down by last year and nobody seems to care about it anymore. Okay, so what difference is all this going to make? Number one, it's going to mean a lot for health and nutrition programs, and you'll learn more about that from other speakers in a moment. But the sort of somewhat abrupt end to the National Emergency Declaration basically means that federal agencies have had to go back to in-person interactions maybe a little more quickly than they had planned. So, for example, the Department of Veterans Affairs has had to return to in-home visits to determine eligibility for caregiver assistance. And this could also impact student loan forgiveness. And we can take down the slides. This declaration was used, the National Emergency Declaration was used by the then Secretary of Education to justify putting a pause on student loan interest and payments during the pandemic. So now there's some debate about whether or not President Biden's plan to forgive up to $20,000 in student loan debt for certain borrowers is now in jeopardy because of the ending of that declaration. Now, this whole topic, as you may know, is tied up in the courts right now, so we'll see how this all plays out in the months ahead. Now, the ending of the public health emergency, which is due to expire next week on May 11th, means that, and maybe this is, people don't necessarily think about this right away when you think about public health, it means that Title 42, which is this obscure provision which gives the Border Patrol broad authority and broad powers to expel migrants arriving at the border, that's going to have to end at the same time that the public health emergency declaration expires next week. And so the Department of Homeland Security is just going to have to go back to using pre-existing laws. It's also important to note that a lot of the programs and authorities that Congress created in those bills, like the Families First Coronavirus Response Act and the CARES Act, a lot of those programs were explicitly linked to the public health emergency. So when the emergency expires next week, all those programs and authorities will end as well, unless Congress wrote some kind of exception into a subsequent law like it did with telehealth, as I described before. So there's so much to this, but I'm gonna stop there. I'm happy to take any questions on this in the chat, so be sure to post your questions there. And so now I'm pleased to turn over to Emily Estes, who's going to tell us all about how this is going to impact access to COVID-19 testing, therapeutics, and so much more.
Awesome. Thanks so much. I'm so glad to be here this morning to talk about this with everyone. I have some slides. It'd be great to bring those up to walk through some of this. Perfect. So I'm going to focus largely on how all of the public health emergency declarations ending impacts COVID pandemic response from the state public health perspective. Next slide, please. As Michael mentioned, there are multiple separate declarations that impact pandemic response. The federal public health emergency ends next week on May 11th. There is a separate emergency use authorization declaration that allows us to use medications like Paxlovid to treat COVID. That is a separate declaration. There is no set end date for that yet. The PrEP Act, which gives some additional flexibilities for liability protections for people who provide COVID care, that is set to go all the way until October 1st, 2024. And then, as Michael mentioned, the California State Public Health Emergency already ended on February 28th of this year. So this kind of just gives the sense that there are multiple intersecting declarations that all kind of impact pandemic response in slightly different ways. Next slide, please. And a few other things impact pandemic response as well. So first, there's the commercializations of vaccines and therapeutics. What this basically means is that products that are currently being distributed by the federal government and given to providers for free will start to go through the regular healthcare delivery system. There's also a federally purchased supply of medical countermeasures like vaccines and therapeutics that are stocked up at this point. And eventually that supply will deplete. This might extend beyond the commercialization date, and the federal government is still working out how they plan to use that stockpiled supply after the date of commercialization. There are also Center for Medicare and Medicaid Service waivers that will expire. There are congressional actions like the Budget Act of 2023 and Inflation Reduction Act of 2022. And then there's California legislation, specifically 2 Senate bills that passed last year that impact what's covered in terms of COVID care for Californians. Next slide, please. This is a very detailed slide. You all will get these slides afterwards. So I know there's a lot of information in here, but basically this goes for every single type of insurance and for the different types of COVID care, so vaccines, therapeutics, and testing, how we expect coverage to change with the end of the federal public health emergency. So one of the main impacts of the federal public health emergency is that a lot of the provisions around what must be covered will start to expire. And that is impacted again by state legislation, like those 2 Senate bills I just mentioned. So I'll highlight a few important things here. Across the board, for Medi-Cal, Medicare, commercial plans regulated in California, and for the uninsured, free COVID-19 vaccines will continue for now. Same with COVID-19 therapeutics. One caveat here that I'll talk about more in a second is that the COVID-19 therapeutics that will continue to be covered for free for the uninsured at this point only include pill medications available at pharmacies. So that would be Paxlovid and Molnupiravir. According to the federal government, the programs that they're putting in place to help continue to cover this will not include monoclonal antibodies. And then testing is a bit more complicated. So for Medi-Cal, free COVID-19 testing will continue, including 8 free test kits per month. For Medicare, the free COVID at-home tests that will expire since that's a federally regulated plan, but COVID testing, if ordered by a doctor, will continue to be covered. For commercial plans regulated in California, free COVID testing, including the 8 home test kits per month, will continue. And then for the uninsured, the free COVID-19 testing that is available through the Department of Healthcare Services COVID-19 uninsured program, that will unfortunately end. Next slide, please. Okay, great. So here is a little bit more information about the U.S. Health and Human Services Bridge Access Program. This is what I just mentioned is the program that will help continue care coverage for the uninsured. So it's a $1.1 billion program that will go through December 2024, there are two main components to this program. The first is support for existing public vaccine safety nets. So the federal government will continue to purchase and distribute COVID-19 vaccines to local health departments and HRSA centers like FQHCs. The idea that the federal government eventually wants to implement is a full vaccines for adults program, kind of like the vaccines for children program. That would include all recommended vaccines that would be covered for free. That has not yet been passed by Congress. So this is sort of a temporary thing in place while they're trying to get that full vaccine program implemented. And then the second part of this is a funded pharmacy program. So the federal government will be paying a per dose administration fee for COVID-19 vaccines and dispensed COVID-19 medications to pharmacies. And then the manufacturers of these vaccines and medications have promised to cover the cost of those medications through patient assistance programs. So what this means is that people who are uninsured, once the pharmacy verifies that they don't have insurance coverage, they won't be paying any costs at the pharmacy to get these medications. Participating pharmacies will have to verify lack of insurance coverage. They'll have to send the CDC some data, and they will also have to conduct outreach regarding the availability of vaccines and therapeutics, especially to underserved populations. Next slide, please. Okay, so for commercialization, what happens here? Again, this is when products that are currently being supplied through the federal government will start to be distributed through the regular healthcare delivery system. So for COVID-19 treatment, the best guess we have right now is that commercialization will occur sometime in the late summer or early fall of this year. Depending on insurance type, consumers may face cost sharing requirements. Again, for federally regulated plans like Medicare, this means that Medicare patients might have to pay some fees for things like Paxlovid after commercialization. Also, we will no longer get provider reporting data from providers that are administering COVID-19 treatment, which will make it a little hard to figure out what the utilization rates for these medications are. For vaccines, the federal government estimates that commercialization will be timed with the start of the fall vaccine campaign. Vaccines will be fully covered by most insurance types. And as I just mentioned, uninsured folks can get vaccines either through the Vaccines for Children program or the HHS Bridge Access program. Next slide, please. Here are just a few key messages that we'd really like to communicate from the public health perspective. So for vaccines, first and foremost, immunization effectively prevents hospitalization and death from COVID-19. Most people are recommended for a dose of the bivalent COVID-19 vaccine. People who are 65 years and older or immunocompromised might benefit from additional doses. Vaccines will be sold on the private market, but still at no cost for most or all patients. For treatment, there are many safe, effective treatment options for people who get sick with COVID-19. These treatments must be started as soon as possible after symptoms start to be effective. So if you think you may have COVID-19, speak with a healthcare provider as soon as possible. Most commonly used treatments will still be free for most people in California. And then last, for testing, at-home test kits will continue to be free, i.e. reimbursable with insurance for most people in the state. California also has a supply of 10 million over-the-counter test kits for local health departments to distribute to community organizations. These resources generally have not been tapped into that much, so we still have plenty left. Next slide. A few quick points about changes in COVID-19 surveillance. So as a lot of you know, with fewer people doing PCR tests and more people doing at-home testing or not testing, there's been a general shift away from case-based reporting. This means that CDC community transmission levels will likely come to an end because test positivity will no longer be available nationwide. Instead, we'll be focusing on key trends like emergency department visits, hospitalizations, deaths, and test positivity just within the state, so just within California. We also are planning on improving our overall respiratory surveillance and integrating this with surveillance for influenza, RSV, and other diseases. Next slide, please. We will also be relying on wastewater surveillance. Here's just a quick example of what that wastewater surveillance data looks like. And we will also be working with our modeling team for COVID-19 and flu projections as well. Next slide. A few more upcoming CDPH plans. Right now, we're developing plans for our stockpiled supply of vaccines and Paxlovid. We are integrating all of our COVID-19 therapeutics testing and vaccines work into an ongoing sustainable structure at CDPH. And then we are also working with other state departments, our local health jurisdiction partners, health systems and providers, and others to support the transition of COVID care to the healthcare industry and collaborate on continuation of some services. Next slide. Very last point, how to stay informed. We encourage people to continue following current CDPH COVID-19 guidance. Right now, we're still awaiting some budgetary information before we know whether certain public communications campaigns will continue to be funded. But regardless, we will definitely continue to provide critical COVID-19 updates with respect to new variants, COVID-19 treatments, and vaccines. We'll be using our CDPH website and social media to share this information, and CDPH officials will provide statements via news releases to make sure that folks stay informed. Local health departments also remain a great resource for staying up to date on COVID transmission rates and COVID programs in your area. I think my next slide is just some resources. And again, this will all be sent out afterwards, but here's a lot of really great places to go if you want to learn more about the end of the public health emergency, any of the federal programs I mentioned, or anything like that. And I believe that is my last slide. I'm happy to answer any questions that come up in the chat. Thank you so much.
Thank you so much, Emily, for that really informative presentation. We had a lot of questions ahead of time on the vaccine, so I'm really glad that you're able to be here with us. And Emily will be back for the Q&A, so please go ahead and continue to put in questions in the chat, so we'll get to those at the end. So now we're going to turn over to a panel conversation, and I'm going to bring on screen our guest speakers, Dottie, Laura, and Alicia, to talk about specifically on the nutrition and the health benefits, what impact the end of these emergency declarations will have on our communities here in California. And so what are the changes that we're expecting to see? What are the estimated impacts? And so we're gonna first talk about nutrition benefits, and then we'll move on to talk about health and health coverage. So we're gonna start with Dottie. So Dottie, let's turn it over to you.
Great, thank you. I'm so happy to be with you today. I have been losing my voice a little bit, so I apologize if I sound raspier than usual, but very happy to be with you. So you can go ahead and put my slides up if you don't mind. That would be great. I'm mostly going to talk about CalFresh, and if I slip up and call it SNAP, I apologize. That's what we call it at the national level, or food stamps, the program formerly known as food stamps. So I have 3 quick points I want to make first, and then I'll get into the impacts of the pandemic-related benefits and the ones that have ended or are soon to end. So the first of the 3 points, you can advance my slides, please. SNAP or CalFresh it works. It really is an effective tool for combating hunger and food insecurity. It reduces poverty, it improves outcomes in education, economic security, and health, and it's a very important support for workers while they are working or in between jobs during periods of unemployment, because the labor market does not provide stable, high-paying jobs. So we have good research now to back up all of these statements that are logically true. Giving people who struggle to afford enough food resources to afford food improves their well-being. The second point I want to make, and you can advance the slide, please, is that SNAP benefits are very modest. Even after a recent increase to SNAP or CalFresh benefits to reflect the costs of affording an adequate diet, they average only $6 a day per person. So I'm bringing up some of these points just because SNAP has been in the news lately and has been under threat. And I think it's important to remember these 2 points. SNAP works, and it is a modest benefit. The costs are not exorbitant and people are not getting a lot of benefits. The final point I want to make in the next slide, and this is a little bit complicated chart, but both points are really important. The first is that if you look at the gray dotted line on this chart, that's food insecurity for all people in the country. And it was held in check during the pandemic, in large part due to the increase in SNAP benefits and other COVID relief efforts, excuse me, such as the child tax credit, the economic impact payments, unemployment insurance, and so forth. So we really saw, as was mentioned earlier, that we're seeing the tangible impacts of the measures that were taken in helping people. But at the same time, food insecurity is too high. There still are people who are food insecure, and those food insecurity is experienced at much higher rates for people who are Black, people who are Hispanic or Latino, people who are Alaska Natives or American Indians. And so, some of those groups experience more than double the national average of food insecurity. So we've been really highlighting this chart to say that as a country, we should be working not only to reduce food insecurity, but to be focusing our efforts on the people who experience the highest food insecurity. Okay, so just quickly to go through, if you could advance the slide, please. There were 4 main COVID temporary flexibilities in the nutrition area. The most important were emergency allotments, which were a substantial increase to SNAP benefits. There were also some eligibility expansions, some administrative simplifications, and then the pandemic EBT program, which provided benefits for groceries on CalFresh cards when children miss school meals. So you can advance the slide, please. February of 2023 was the last month that these substantial increase in SNAP benefits was in effect. Congress had enacted this at the very beginning of the pandemic. It was enacted in March of 2020, went into effect very quickly. Most states got benefits out in April or early May, and households received at least $95 a month to help meet basic food needs. A lot of households got way more than that. So that ended after February benefits. All households saw at least a $95 per month cut. The average cut is about $90 per person per month. And we're starting to actually see state reported data that show the cuts we were expecting to see. California has not yet posted data, but you can see some of the states that have. We had estimated that in California, it would be about an $84 per person cut, going from $280 average in February to about $196 per month in March and future months, a 30% cut. And aggregated across all of California, that's our estimate was about $425 million per month, which is a substantial amount of resources going into communities, going into the economy, and of course, helping people to afford food and to, have their other money available to meet other important basic needs. So, these are very big cuts. These are the averages. Some households are seeing cuts of $250 a month or more. And all of this is happening at a time when food prices are high. And so it's a big challenge for people. And we're starting to hear, not surprisingly, that area food banks all across the country in the areas where benefits have been cut, which is now all across the country, are starting to have increased demand for emergency food. I was asked to talk about ways that we could compensate for some of these losses. I think I'll go through my slides and see if we have time, but I can certainly come back to that in the Q&A. The second thing I wanted to talk about is temporary eligibility expansions for people who normally are subject to SNAP's 3-month time limit. which in most of California has been not in effect for much of the last 10 years or more, and will continue to not be in effect at least until late 2024, because California, based on relatively high unemployment rates, still qualifies for a statewide waiver. So that's good news, that California won't have to re-implement that provision, which many parts of the country are going to be re-implementing this summer. The second eligibility expansion was an expansion to college student eligibility to acknowledge the fact that the pandemic upended college students' lives, as it did everybody's, but changed their living situations and so forth. So it expanded CalFresh eligibility to students who are eligible for work study and to students who have a financial aid expected family contribution of 0. So those are families that come from lower income backgrounds. Those expansions are ending at the end of the public health emergency, and individual households will have their eligibility for CalFresh reassessed when they come up for recertification beginning this summer. And then the last SNAP provisions were administrative simplifications. I believe these were things that Congress and USDA did in order to help keep people connected to food assistance and help the states to be able to process new applications as they came in. I believe California is no longer using any of these waivers and has returned to regular program rules. I also, just want to flag that the Medi-Cal unwinding that we'll be talking about next could also have a big impact on CalFresh operations, because in California, those two benefits are processed together. And so delays in processing or difficulty that people have contacting the Health and Human Services agencies, the county offices, could certainly have an impact on both programs. And the last provision was the pandemic EBT program, which was a new temporary program that provided grocery benefits for children on SNAP CalFresh cards for the meals that they missed out on because schools were closed. That is actually going to continue in a different form. In this coming summer, it will continue as pandemic EBT. And then starting next summer, states will launch a new permanent summer EBT program that will have some similarities and some differences to the pandemic program, but will be similarly the first time that food assistance benefits are widely available during the summer months to children who qualify for free and reduced price school meals. So thank you. I'm going to return it over now to my colleague from the Center on Budget and Policy Priorities, Laura Guerra-Cardis, to talk about the impact of the end of Medi-Cal's continuous coverage provisions.
Hi, everybody. Thanks, Dottie, for that. I'm going to be talking about, really providing a high-level overview of the continuous coverage requirement in Medicaid and what it means to unwind it. And then I'll pass it on to Alicia to talk about this issue from a more local perspective. We can go to the first slide. The next slide, please. Thank you. So in March of 2020, as part of the pandemic era legislation, Congress provided increased Medicaid funding to states with a few conditions. One of them was that they could not terminate people's Medicaid coverage until after the PHE ended. This is called the continuous coverage requirement or protection, and was provided at a time when millions of people were losing their jobs and with it their health insurance, when people really needed access to healthcare coverage. So on the ground, this continuous coverage requirement meant that if you were enrolled in Medicaid already, or you got enrolled newly during the public health emergency, you remained enrolled without needing to take action, like doing your regular renewals to determine eligibility. You could voluntarily disenroll, but the state agencies could not terminate your enrollment. Now, there was legislation passed at the end of 2022, of last year, that severed the PHE declaration from this continuous coverage requirement, and it marked an end date for the requirement, which was March 31st. And so as of April 1st, people enrolled in Medicaid could once again have their coverage terminated. And this this kind of termination of this requirement really launched Medicaid state agencies across the country into having to redetermine eligibility for every single person enrolled in their Medicaid program, which is an enormous amount of work, considering that the latest estimates are that 86 million people are enrolled in Medicaid. It also launches our work to ensure that Medicaid enrollees know that their regular renewals are going to be restarting again and that they must complete the renewal process or risk losing coverage. Because of the scale of the number of people who could have their health coverage impacted, this is considered the largest health coverage event since the implementation of the ACA. Next slide. Okay, great. So this process of redetermining everyone's coverage within 14 months, which is the allotted time, is known as the unwinding. All enrollees will need to complete a full renewal, and if they don't, their coverage could be terminated. Experts estimate that 18 million people could lose healthcare coverage during this 14-month unwinding period. And projections also show that about half of those people will actually remain eligible for Medicaid. And we'll talk a little bit more about why that is and what we can do about it. State agencies, often already understaffed, will experience substantial workload increases during this unwinding, which is why states should really focus on improving their renewal processes to minimize this risk. And our organization, as well as many others, have been working with state agencies for over a year now to encourage them to improve those processes. Next slide. All righty. So this slide talks about the potential outcomes. So as people eligibility is being redetermined in Medicaid, they could fall into three different buckets. One is they are no longer eligible for Medicaid, but they have another form of coverage, which is great. And we're not worried about that group. The next group is the folks who are ineligible for Medicaid, but need help transitioning to another form of coverage. Often it's marketplace coverage. Most people who will no longer be eligible for Medicaid will have access to coverage in the marketplace, and many of them will actually be eligible for zero subsidy plans. Now, this green and yellow buckets are about half of the folks expected to lose coverage. The other half, it's slightly under, it's 45%, are people who are eligible for Medicaid. They remain eligible for Medicaid, but they have lost their coverage because of procedural reasons. Next slide. And so how could that happen? There's a few reasons for that. On the Medicaid enrollee end, it might be that they didn't receive their renewal notices, or they received them, but they didn't quite understand. We must remember that folks have not had to renew their coverage for three going on 4 years. And they also may have trouble submitting the information that is requested in the time period allotted. But that's not all the issues that could arise. A lot of issues could happen on the state agency side because they are going to be so overloaded with work. They might not be able to process documents in a timely manner, or there could just be errors made. And so what's going to happen is that many people will end up reapplying, and this will lead to additional paperwork for already overloaded agencies, and gaps in coverage can result whether gaps in coverage actually can result whether folks remain eligible for Medicaid or are transitioning to other coverage. And of course, there's increased costs associated with that. Next slide. The Urban Institute and ASPE, and I put the sources there, are really great sources for estimates and projections on who is most likely to be impacted. And when you look at the data, children and people of color are really most at risk. More than half of those who are projected to lose healthcare coverage yet remain eligible are going to be children. So that's about 4 million children. And there's many more in addition to that 4 million children that may not be eligible for Medicaid, but will be eligible for CHIP and should be transitioning there ideally without gaps in coverage. The other kind of remarkable statistic is that more than 1/3 of the people expected to lose coverage yet remain eligible for Medicaid are Latino. And for this population, immigrants or people who have family members who are immigrants may face unique challenges in completing the renewal process and are a group that we have to be really thoughtful in reaching out to. Next slide. And so this is another slide just about the disproportionate impact. And I like to think about it kind of from the community perspective. If you hear of a child who has lost their Medicaid coverage, 3 out of 4, there's a 3 in 4 chance that that child will remain eligible for Medicaid. For a Latino person, it's a 1 in 2 chance, and you can see the other statistics there and just the disproportionate impact on communities of color. Next slide. Many of the challenges that enrollees will experience throughout the unwinding process are administrative burdens, and administrative burdens disproportionately impact people of color. So unwinding really is a key moment for us to think about racial equity and ensuring that support and resources are there to help people of color remain connected to coverage. Next slide. So how do we maximize opportunities to prevent coverage loss? There's kind of 3 buckets. One is robust outreach and communications. This is necessary from the agency side, but also at the community level, which I'll get into in a bit more detail in a second. The second is on the agency side. And again, many organizations have been advocating for years now for state agencies to prepare and ensure they have strong renewal processes that help them minimize the workload and streamline processes so that eligible people are not losing coverage. And the third bucket is doing what we can to facilitate transitions to the ACA marketplace. Next slide. I like to focus on the community side of what we can all do, because there is something everybody can do to help prevent coverage loss for those projected 18 million people who are at risk. And helping prevent coverage loss really requires that kind of all hands on deck effort. So in addition to kind of all of us seeing what part we can play in this, great community partners to engage include schools, especially through the state associations, Spanish and other non-English language media, food banks, and organizations that have a lot of direct contact with impacted communities, like daycare workers, and also thinking about foundation partners, which we know we have a great partner here for that. In terms of resources, these are some of my favorites. The first one we put together at the Center on Budget and Policy Priorities, Partner Engagement Talking Points. This is a way to explain this issue in a very simple way that you might use with the media, particularly non-English media, to really help explain this issue from the perspective of individuals and families that are going to be impacted. And also it helps make the case on the need to really specifically reach out to the communities that are going to be most impacted, children and people of color, and why partners should be engaged in this work. The second is a school toolkit with the American Association of School Administrators. The Center for Children and Families put together a state-specific resource page that can feel a little overwhelming, but if you look at column E, It has some state-specific materials, but I know Alicia can talk a bit more about that. And then the last two links are to CMS materials that can be downloaded, and a group called Organizing for Outreach has a lot of like ready-made tools that can be customized. Next slide. And so to put simply, these are really the 5 key messages that we want everybody's help in getting out to the community. Making sure people know that everyone on Medicaid must renew their coverage, that they should update their contact information so that Medicaid knows how to reach them, that they should be on the lookout for notices and free unbiased help is available, and that if you no longer qualify for Medicaid, you have other options. And a 6th one that is not written here, but I would like to add is a specific message for immigrant communities, that it is safe to apply for and enroll in these coverage programs, because we know we still have work to do in helping families feel safe in accessing programs that they qualify for. And with that, I will pass it on to Alicia.
Great, thank you. Hi, everyone. My name is Alicia Emanuel. I'm a senior attorney at the National Health Law Program here in our California office. And I'm going to build off of Laura's presentation and do a deeper dive on what is happening on the ground in California specific to the Medicaid continuous coverage unwinding. And if we could pull up my slides, that would be helpful. Thank you so much. Next slide, please. So what you see here on the slide is the latest data. Well, it's a projection. So first off, right now there are nearly 15.8 million people in California enrolled in Medi-Cal coverage. This is an all-time high. It's been a great access to care and services for Californians. Unfortunately, due to the Medicaid continuous coverage unwinding, it's estimated that 2 to 3 million people will be cut off of coverage. As Laura mentioned, some people will be cut off coverage because they are no longer eligible, while others will be cut off despite being eligible. So what you see here on the graph is an estimate of the Medi-Cal renewals per month based on prior data. You'll notice that every month is slightly different, and that is about what we'd expect over the course of California's unwinding period. Next slide, please. I want to take a moment to discuss the timing of California's unwinding. As Laura mentioned, the Medicaid continuous coverage protection that kept people on March 31st. In April, counties started the first set of renewals that are due in June. And this means that in early April, counties attempted to do automatic renewals, also known as ex parte renewals. And only if these were unsuccessful did counties send out renewal packets to Medi-Cal beneficiaries in the 3rd week of April. In blue font on the slide is where we're at right now. So in May, so now reminders are starting to go out to beneficiaries if their renewal packet hasn't been returned and if renewals aren't completed. California will see the very first Medi-Cal terminations as of July 1, based on June renewals. And just a note that California is performing renewals in each person's normal renewal month. So everyone has a different renewal month, and Medi-Cal beneficiaries will stay on coverage until their renewal month comes up. Next slide, please. There's no doubt that the unwinding is a monumental undertaking. In an effort to ensure that the process goes smoothly and facilitate continued coverage for individuals who are entitled to continued Medi-Cal coverage, California adopted more than several flexibilities to streamline renewals during the unwinding. These flexibilities are known as 1902E14A waivers that are approved by CMS. So on this slide is a list of all the approved flexibilities at this point in time. For the sake of time, I'm not going to go through all of them, but I did want to highlight the one at the top, which is that in part due to state advocacy efforts, the state recently sought and received approval to waive the asset test during the unwinding. So this means that Medi-Cal will not count assets and property for Medi-Cal renewals this year or ever again, because in January of 2024, assets are being eliminated. If you want more information about the details of California's unwinding policies, you can check out the California Operational Unwinding Plan at the link at the bottom of this slide. Next slide, please. There are a few key state policy decisions that I wanted to lift up. So one, the Department of Healthcare Services is deprioritizing renewals for immigrants aging out of our young adult expansion population. Young adult expansion currently provides comprehensive Medi-Cal to individuals up to age 26, regardless of immigration status. So for immigrants who turn 26 during COVID, they will stay on Medi-Cal coverage until the 26 to 49-year-old Medi-Cal expansion rolls out in 2024. This is great news. Two, early on in the pandemic, California implemented a COVID uninsured group program, which provided and still provides coverage for COVID testing related services, and COVID treatment for uninsured and underinsured individuals. Over 500,000 people were enrolled in this program here in California, many of whom were immigrants. This coverage ends May 31st. Notices have already started to go out to this population, and the state has created a toolkit in English and Spanish that can be found on the landing page on my slide to inform people about their right to seek out Medi-Cal and Covered California coverage once the program ends. And three, I wanted to highlight SB 260, which is a bill that will provide automatic transitions from Medi-Cal to Covered California, our state-based exchange, for individuals who are found ineligible for Medi-Cal. This seamless transition will help facilitate continuous coverage and reduce gaps in coverage as people transition to the exchange. Next slide, please. So there's a large outreach and education campaign set up to support the unwinding and make sure individuals and families are aware of their responsibilities and their rights as renewals restart. Medi-Cal beneficiaries can sign up for renewal alerts at keepmedicalcoverage.org. This landing page is available in English and Spanish, and it's recently been updated to provide specific instructions so you can seek out information on how to update contact information, how to complete a renewal form, what to do if you get a notice of termination, etc. Stakeholders can also sign up to be a coverage ambassador. It's not a large obligation. You just receive timely information and materials from the state related to the unwinding. The department has also developed a robust outreach toolkit, which includes call scripts, emails, flyers, social media graphics, and videos that can be used by any and all organizations and advocates on the ground to spread the word about renewals resuming. And these materials have recently been translated into all 19 Medi-Cal threshold languages. And to the right of the slide is one of the graphics from the toolkit. Next slide, please. Several high-level messages I want to lift up. One, that Medi-Cal beneficiaries should be updating their contact information with the county right now if they haven't already. Two, beneficiaries should also be checking their mail for a yellow renewal envelope. And they might also get calls from their county. 3, if they haven't already, they can start an account at benefitscal.com to get information about their renewal and also find out their renewal month. 4, beneficiaries have a right to submit their renewal information by phone, online, by mail, or in person. 5, people have a right to request a state fair hearing if they think the county got it wrong, or they were already terminated from coverage. And 6, we want to remind beneficiaries that they have the right to submit their renewal paperwork even after their Medi-Cal coverage ends during what's called the 90-day cure period. Next slide, please. If Californians need support to complete their renewals, here are 2 great resources. One, the Health Consumer Alliance is a statewide consortium of legal aid organizations that provides free and confidential assistance to California healthcare consumers. My organization is part of the HCA, so I listed the toll-free number there, the website, and please know that translation services are available. And 2, we wanted to make sure people are aware of their local navigator groups. So on the slides is a link there to your local navigators that can help with completing renewals. Next slide, please. And finally, here's my contact information. If I can be of more help, my email and my phone number are available to you. And that concludes my slides, and I will pass it back to you, Marisol.
Great. Thank you so much, Alicia and Dottie and Laura. That was very informative, very helpful information. And we are going to bring everyone back on screen. And I know we wanted to touch briefly on any policy conversations or any opportunities to fill some of the gaps. So I don't know if there's maybe a quick response from any of our panelists just on that question of, the policy landscape. I know there's a lot of conversations on SNAP, and so if anyone has a quick insight on that, that would be appreciated.
Hi, everyone. I'm happy to go first. I think something to note in healthcare coverage, which is my area, is that the pandemic and the pandemic era policies that were put in place really lay a roadmap to continued policy making. In healthcare coverage, the pandemic was a time where we really should have seen uninsured rates skyrocket and people losing their kind of coverage at large scale. But we actually saw improved coverage rates. We reached our lowest rate of uninsured in the country. We tied it with the lowest ever rate of uninsured. And so that tells us that continuous coverage or continuous eligibility provisions really work to decrease churn and to make sure we can keep people connected to coverage and lower our uninsured rates. And we did learn from that. The end of the year legislation that was passed actually provided 1 year of continuous coverage or continuous eligibility for kids in Medicaid and CHIP as a national standard. So that is a huge accomplishment that that is one example of how we are using the lessons that we learned during the pandemic. And we also see some states like Oregon and Washington applying for waivers, and these 2 states got waivers approved to provide continuous eligibility for kids through their 6th year. And then in one of the states, I think it's Oregon, the kids would then, after 6 years old, only have to renew every 2 years, every 24 months. So that is all really good stuff. It's a bit frustrating that right now at the national level, we are having the opposite conversation about putting new requirements for people in Medicaid and SNAP and other programs that create more barriers, more paperwork, and go in the opposite direction of where we'd like to be seeing things going. So, a lot that we have learned, a good roadmap ahead. but the need to really underscore that our goal here is to continue to help people access programs that they're eligible for, and not and need to focus on removing barriers to that access.
And this is Alicia. Sorry, I'll just add in really quickly that here in California, in the Golden State, we are certainly marching ahead in terms of ensuring access to coverage and care for all Californians. So I mentioned in my presentation that we will, as of January 1, 2024, be expanding comprehensive Medi-Cal coverage to our 26 to 49-year-old population. And with that last expansion, we'll have hit all the age groups that can be eligible for Medi-Cal if folks are low income. And there are also currently efforts underway to try to expand exchange coverage as well to our immigrant population.
Yes, and those are very, very exciting developments. So I know we're running out of time. This was a really great conversation, and I think there's a lot more that we can talk about on the policy front. So this is making me think we need a part 2 to this webinar potentially, and so let's think about that because I think there's a lot more here that we can talk about. And so there were some questions in the chat, and we're sorry we won't be able to get to all of them. I want to be mindful of everyone's time, but we will include the questions in the follow-up email that everyone will receive, and we'll include some responses to those questions. Thank you so much, everybody. I know that we went over, and I want to appreciate Michael, Emily, Dottie, Laura, and Alicia for this very informative conversation, and for all of you for joining us today. Please fill out the survey that we'll be sending out after the webinar, and we will send you the slides as well as the recording. And we hope to see you at a future Policy Perspectives webinar. Have a good day. This concludes our program.